Good day, everyone. Today, I'd like to take you on a journey through the intricate landscape of lower respiratory infections. While most respiratory infections we encounter in the clinical setting are confined to the upper airway, it's imperative to recognize and understand those that affect the lower respiratory tract, given their potential severity and complexity. A general overview of respiratory infections. In our day-to-day practice, patients frequently present with symptoms like a productive cough, fever, dyspnea, or pleuritic chest pain. These symptoms prompt us to ask critical diagnostic questions. Is the infection limited to the trachea and bronchi, or has it progressed to pneumonia? Should we initiate a diagnostic workup, or is it prudent to start empiric treatment immediately? Are antibiotics warranted in this scenario? And if so, which ones would be most effective? Can we manage the patient safely as an outpatient, or does their condition necessitate hospitalization? These questions become even more nuanced when dealing with HIV-positive or immunosuppressed patients, where the usual clinical cues may not apply and the stakes are considerably higher. Pathophysiology and defense mechanisms. Understanding how microorganisms invade the lower respiratory tract is crucial. They gain access primarily through inhalation of airborne particles or aspiration of oropharyngeal contents. Our bodies are equipped with remarkable defense mechanisms to combat these invaders. Mucus and ciliate epithelium trap and expel pathogens. Immunoglobulin A, IgA, provides immune protection on mucosal surfaces. Cough reflex helps clear secretions and foreign material. Alveolar fluid and macrophages engulf and destroy pathogens at the alveolar level. However, several factors can weaken these defenses. Smoking and alcohol use impair mucociliary function and macrophage activity. Immunodeficiency, whether due to disease or immunosuppressive therapies. Pharmacologic agents. Certain medications like antipsychotics and proton pump inhibitors can increase susceptibility. Interestingly, some agents offer protective benefits. For instance, angiotensin-converting enzyme inhibitors, ACEIs, have been shown to reduce the risk of pneumonia. Adding another layer to our understanding of these conditions, clinical presentations. Distinguishing between bronchitis and pneumonia is vital, yet sometimes challenging due to overlapping symptoms such as cough, fever, fatigue, and chest discomfort. Bronchitis typically does not show infiltrates on a chest X-ray. In pneumonia, may present with pleuritic chest pain, dyspnea, and signs of lung consolidation. Chest X-ray will reveal infiltrates. When considering community-acquired pneumonia, CAP, most cases are mild with a good prognosis when treated appropriately on an outpatient basis. In contrast, healthcare-associated pneumonia often involves more severe disease, prolonged hospital stays, and higher mortality rates. Key organisms. Let's delve into the microorganisms commonly responsible for these infections. Gram-positive organisms. Streptococcus pneumoniae, the most common cause of CAP. Patients may present with fever, rusty-colored sputum, and pleuritic chest pain. Complications can include bacteremia, empyema, and meningitis. Staphylococcus aureus often follows viral infections and can cause lung abscesses and severe necrosis. It's common among drug users and in nosocomial settings. Group A streptococci, known for abrupt onset and rapid spread within the lungs, leading to complications like empyema and, rarely, glomerulonephritis. Gram-negative organisms. Haemophilus influenzae, associated with chronic lung diseases. Encapsulated strains can cause severe infections. Klebsiella pneumoniae, frequently seen in alcoholics. Characteristic features include current jelly sputum and necrotizing infections. Moraxella catarrhalis causes mild infections, usually in COPD patients, and many strains produce lactamase. Atypical organisms. Mycoplasma pneumoniae, a common cause of atypical pneumonia with symptoms like dry cough and erythema multiforme. Chlamydophila pneumoniae leads to mild, self-limited atypical pneumonia. Legionella pneumophila, associated with contaminated water sources and can cause severe CAP. With systemic symptoms: zoonotic and mixed flora infections, psittacosis, transmitted from birds, presenting with non-productive cough and fever, Q fever, linked to animal exposure, particularly livestock, and features pneumonia with prominent hepatitis, aspiration pneumonias, result from mixed flora infections, especially in patients with altered consciousness or diminished gag reflex, leading to complications like lung abscess and empyema. Non-bacterial organisms of viruses and fungi. Viruses are responsible for over 80% of acute bronchitis cases and can clinically resemble atypical pneumonia. Common viruses: influenza, adenoviruses, respiratory syncytial virus, RSV, and parainfluenza virus. Influenza virus, the most significant cause of viral pneumonia, characterized by epidemic spread, fever, myalgia, and respiratory symptoms. Complications often include secondary bacterial pneumonia. H1N1, 2009, presented with fever, cough, shortness of breath, nausea, myalgia, and sore throat. It notably affected children, young adults, and those with comorbidities, with rapid progression in severe cases. Severe acute respiratory syndrome, caused by a novel coronavirus with progression to respiratory distress. Diagnostics revealed multilobar infiltrates and laboratory abnormalities. Mortality 10–15%. Fungi and opportunistic organisms. In immunosuppressed patients, fungi like Aspergillus, Candida, and Pneumocystis jirovecii are common pathogens. Even immunocompetent individuals can be affected by fungal infections such as histoplasmosis and coccidioidomycosis, especially when exposed to spore-containing dust. Symptoms: non-productive cough, flu-like illness, hepatosplenomegaly, alveolar infiltrates, and hilar adenopathy. Diagnosis can be challenging due to often normal chest X-ray findings. Differential diagnosis: when assessing CAP, it's important to consider bacterial causes. Streptococcus pneumoniae, most common, Haemophilus. Influenzae, viral causes, influenza virus. Other pathogens: Legionella pneumophila. Non-infectious conditions that can mimic pneumonia include bronchial asthma, hypersensitivity pneumonitis, atelectasis, pulmonary infarction, pulmonary edema, lung tumors. Chronic diseases like bronchitis and bronchiectasis may have misleading radiologic findings, emphasizing the importance of comparing with prior imaging. Workup for lower respiratory tract infections. Initial differentiation: distinguish lower respiratory infections from upper respiratory infections, characterized by nasal discharge, sore throat, ear pain. Other causes of cough, such as bronchial asthma and hypersensitivity pneumonitis. History: while certain symptoms are unreliable in differentiating bronchitis from pneumonia, e.g., type of cough, presence of fever or dyspnea, assessing comorbid conditions is crucial for prognosis. Advanced age, heart failure, cerebrovascular disease, malignancy, renal liver disease. Identify risk factors for specific pathogens. Drug-resistant S. pneumonia, age greater than 65, alcoholism, recent lactam use, gram-negative organisms, K. pneumonia, alcoholism, H. Influenza and M. Catarrhalis, chronic lung disease, opportunistic pathogens, immunosuppressed patients, e.g., pneumocystis jirovecii, M. Tuberculosis. Consider epidemiologic and exposure history. Birds, psittacosis, livestock, Q fever, rabbits, tularemia. Geographic areas, coccidioidomycosis in the southwestern U.S., histoplasmosis in the Midwest. Travel, exposure to hotels, cruise ships may suggest Legionella. Physical examination, focus on vital signs and pulmonary examination, indicators of poor prognosis. Fever greater than 104 degrees Fahrenheit, hypothermia, tachypnea, tachycardia. Pulmonary findings, crackles, common in both pneumonia and bronchitis. Consolidation signs, dull percussion, egophony, specific to pneumonia but present in less than 25% of cases. Laboratory studies, acute bronchitis, generally diagnosed based on history and physical exam. Influenza testing, PCR testing, gold standard using nasal swabs, rapid antigen tests, high specificity but lower sensitivity. Procalcitonin levels may guide antibiotic use but need further validation. Pertussis diagnosis, PCR testing, most sensitive using nasopharyngeal swabs. Serology, elevated pertussis antibodies for symptoms lasting more than 4 weeks. Pneumonia, chest X-ray, gold standard for diagnosis, assessing extent, effusion, or empyema. Sputum analysis, gram stain and culture, recommended for hospitalized patients. Adequate specimen, fewer than 10 epithelial cells and more than 25 polymorphonuclear cells per low-power field. Blood cultures, positive in 5 to 15% of cases. Essential for suspected pneumococcal disease. Legionella testing, urinary antigen test, rapid and sensitive for L. Haemophila serogroup 1. Culture, confirmation in 3 to 5 days on specialized media. Pneumococcal urinary antigen, 70 to 80% sensitive, facilitates earlier narrowing of antibiotic therapy. Additional testing for severe or immunocompromised patients. Serology, for Mycoplasma, Chlamydophila, Coxiella, and viral agents. Induce sputum bronchoalveolar lavage, for pathogens like Pneumocystis jirovecii or M. Tuberculosis. Hospitalization considerations, complete blood count, renal function tests, BUN, creatinine, serum electrolytes, assess hyponatremia. General measures and overview. Let's begin by discussing the foundational aspects of managing lower respiratory infections, admission versus outpatient management. One of the first decisions we face is determining whether a patient requires hospitalization or can be safely managed as an outpatient. Outpatient treatment, suitable for patients who are alert, reliable, and show no signs of serious compromise. The Port trial demonstrated that approximately 50% of patients could be classified as low risk for complications, with less than a 1% 30-day mortality rate. Therapeutic levels with oral antibiotics. Advances in oral antibiotic formulations allow us to achieve therapeutic serum levels without hospitalization. Symptomatic and supportive measures. Managing symptoms and providing supportive care are essential components of treatment. Cough management, suppression, generally discouraged unless the cough causes severe discomfort or disrupts sleep. The cough reflex is vital for clearing secretions and pathogens. 2 agonists, medications like albuterol may help reduce the duration of the cough, especially if bronchospasm is present. Cough suppressants, for nighttime relief. Dextromethorphan or codeine can be effective in suppressing cough and improving sleep quality. Hydration and secretions, fluid intake and humidification. Encourage patients to stay well hydrated and consider using humidifiers to help mobilize and thin secretions. Expectorants, agents like guaifenesin may provide additional benefit in loosening mucus. Fever management, antipyretics. Medications such as aspirin or acetaminophen are recommended to control fever and alleviate associated discomfort. Oxygen therapy, hypoxemia management. Oxygen therapy is indicated for hospitalized patients experiencing hypoxemia. Oxygen should be carefully titrated based on the patient's respiratory status. Chronic lung disease considerations. In patients with chronic lung conditions, avoid excessive oxygen to prevent hypercapnia and potential respiratory depression. Specific conditions and treatments. Now, let's explore specific respiratory conditions and their tailored treatment approaches. Acute bronchitis. Antibiotic use. Generally not recommended for healthy patients since acute bronchitis is often viral in origin. Conservative measures. Focus on symptomatic relief and educate patients about the natural course of the illness. Exception: pertussis. For suspected or confirmed pertussis, whooping cough, antibiotics are indicated to reduce transmission and severity. Macrolides. Azithromycin, 500 mg on day 1, followed by 250 mg daily for 4 days. Erythromycin, 500 mg 4 times daily for 7 to 14 days. Acute exacerbation of chronic bronchitis. Common pathogens: Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. Antibiotic choices: uncomplicated cases, cefuroxime is effective. Severe elderly patients, amoxicillin, clavulanate, 2g twice daily, is recommended. Alternatives: respiratory fluoroquinolones, second-generation macrolides, or trimethoprim, sulfamethoxazole. Community-acquired pneumonia, CAP, healthy young adults, first-line treatment, erythromycin, 500 mg 4 times daily. Alternatives: azithromycin, 500 mg on day 1, then 250 mg daily for 4 days. Clarithromycin, 500 mg twice daily for 7 days. Doxycycline, 100 mg twice daily. Respiratory fluoroquinolones, reserved for resistant cases, e.g., levofloxacin, moxifloxacin. Duration: typically 5 to 7 days, may be shorter if the patient is afebrile for 48 to 72 hours. Older adults and comorbidities. Combination therapy: second-generation macrolide, azithromycin or clarithromycin, plus lactam antibiotic, amoxicillin 1g 3 times daily or amoxicillin, clavulanate 2g twice daily. Alternative: respiratory fluoroquinolones as monotherapy, hospitalized patients, first-line treatment, third-generation cephalosporin, ceftriaxone 1g daily, plus macrolide, azithromycin 500 mg daily or clarithromycin 500 mg twice daily. Alternative: respiratory fluoroquinolones alone, management of influenza, antiviral therapy. Most effective when started within 48 hours of symptom onset. Zanamivir, administered via inhaler twice daily. Oseltamivir, 75 mg twice daily. Benefits: reduced symptom duration, decreased hospitalization rates, and lower mortality in high-risk groups. Prevention: annual vaccination, frequent hand-washing, and mask use are key preventive strategies. Antibiotic resistance in S. pneumonia. Rising resistance. Penicillin resistance is increasing, with up to 10% of strains highly resistant. Alternative treatments: respiratory fluoroquinolones, higher dose lactams, and macrolides are effective against resistant strains. Vaccination impact: the 23-valent pneumococcal vaccine and pediatric conjugate vaccines have helped reduce resistance prevalence. Antibiotic therapy for pneumonia. Tailored treatment: antibiotic therapy should be matched to the clinical syndrome and most probable pathogens. Empiric recommendations, provided based on various clinical scenarios and specific infectious agents. Monitoring therapy. Effective monitoring ensures that patients are responding to treatment and helps identify any complications early. Clinical improvement. Vital signs. The best indicators of improvement are normalized temperature, respiratory rate, heart rate, and blood pressure. Timeline: median time to normal vital signs is approximately 3 days post-hospitalization. Patients typically become afebrile around 6 days. Switching therapy. Transitioning. Once clinical stability is achieved, switch from intravenous to oral antibiotics. Discharge criteria, normal vital signs, stable mental status, and the ability to take oral medications indicate readiness for discharge. Radiologic monitoring, routine imaging, not necessary if the patient is improving clinically, as radiographic resolution may lag behind. Indications for imaging. Persistent fever, worsening symptoms, or suspicion of complications like lung abscess or empyema. Warrant further imaging. Follow-up X-rays. High-risk patients, recommended for patients over 50, smokers, and males to rule out underlying malignancies. Yield. Studies have found a detection rate of up to 2.8% for malignancies in these groups. Patient education and prevention. Empowering patients through education can significantly impact recovery and prevent future infections. Natural history of illness, acute bronchitis. Inform patients that the cough may persist for 1 to 2 weeks, but significant improvement is expected by the end of the first week. Pneumonia. Recovery may take longer. More than 50% of patients report fatigue and cough 1 month after diagnosis. Monitoring at home. When to seek help. Advise patients to contact their healthcare provider if they experience persistent fever, worsening respiratory symptoms, or confusion. Smoking cessation. Opportunity for change. Illness often motivates patients to quit smoking. Encourage cessation to improve recovery and reduce future risk. Vaccination. Pneumococcal vaccine. Indications. Recommended for individuals over 65, those with chronic heart or lung conditions, immunosuppressed patients, and post-splenectomy individuals. Vaccines. Pneumovax. 23-valent covers about 90% of pneumococcal pneumonia cases in the U.S. Prevnar. 13-valent advised as the initial vaccine for immunocompromised or asplenic patients. Revaccination. After 5 years for immunosuppressed patients or those vaccinated before age 65. Influenza vaccine. Annual immunization. Strongly recommended for all, especially high-risk groups. Contraindications. Patients with egg hypersensitivity should not receive the vaccine. Co-administration can be given alongside Pneumovax without increased side effects. Antiviral chemoprophylaxis. For unvaccinated high-risk patients, Zanamivir, inhaled, as prescribed, oseltamivir, 75 mg. Twice daily. Preventive measures, early and frequent hand washing, along with mask use, can reduce transmission risk. Indications for admission. Determining the need for hospitalization is critical for patient outcomes. Predictors of poor outcomes. Risk factors, advanced age, existing comorbidities, abnormal vital signs, and immunosuppression increase the risk of complications. Risk assessment tools. Pneumonia Severity Index, PSI. Classification assigns patients to risk classes based on age, comorbid conditions, and vital signs. Low risk, a PSI score below 90 indicates low mortality. Curb 65 rule. Criteria. Confusion, uremia, BUN greater than 20 mg per deciliter, respiratory rate, greater than 30 breaths per minute, blood pressure, systolic, less than 90 mm of mercury or diastolic less or equal to 60 mm of mercury, age 65 years or older, mortality rates, no risk factors, approximately 0.7%, one risk factor, approximately 2.1%, clinical judgment, individual assessment, always consider the unique circumstances of each patient. Clinical intuition may suggest hospitalization even when risk scores are low, such as in young patients with severe symptoms. Alternative care, managed care options, for suitable patients, home intravenous therapy or care in subacute facilities can be effective alternatives to hospitalization. Thank you for joining me on this journey through the critical aspects of lower respiratory infections. If you found this lecture insightful, I encourage you to share it with your colleagues and peers. Your engagement and commitment to learning not only enhance your practice, but also contribute to the well-being of the patients we serve. Let's continue to inspire each other, stay curious, and strive for excellence in patient care. Together, we can make a profound difference in the lives of many.